if you truly have changes at the joint level that are limiting your motion, they should be fairly consistent. They shouldn't change from day to day and week to week, et cetera.
Right.
And I know that's what I find in myself. That's what I find with many patients is, one day they come in and they can't turn their head, and without any interventions, you might see that, they're 7 days later, they're actually able to move in a different way again. And I do think that goes to things like neurophysiological components of perceived stiffness.
Welcome to the Next Level podcast. I'm your host, Scott Dickinson. Dr. Laurie Devaney hails from the University of Connecticut, where she works as a neck researcher, program director for the Doctor of Physical Therapy program, co-director at the UConn Institute of Sports Medicine, and associate professor in residence. Go Huskies. I'm going to warn you, we really nerded out on the neck in this discussion. To this conversation, Laurie brings her experience and perspective as a clinician, but also the status as a bona fide researcher. And what I liked most is that she isn't afraid to speculate, to speak on ideas, and share her opinion. So because of all this, I'm so excited to bring you my conversation with Dr. Laurie Devaney. Please enjoy. Okay, Laurie, welcome to the Next Level podcast. Thank you for taking your time today to speak with me. And it's a pleasure to have you here.
Yeah, thanks, Scott. I appreciate you inviting me. I'm looking forward to it.
So I first came in contact with you through just a cold email. Some athletic trainers / PTs within a professional baseball organization told me about your work and said, are you familiar with her? Embarrassingly, the answer was no. And so I reached out, and since then we've sent you a Next Level, and I've gotten more familiar with your research. Do you mind backing up and talking to me about how you got into neck research and your flagship product, the CPG, and how that all came to be back in 2017 or so?
Yeah, sure. So I've got to actually take a step way back because I'm a big Boston Red Sox fan, as you can probably see from the picture that's behind me there. But sometime in the 90s, Pedro Martinez had a stiff neck and was scratched in the lineup. And I can remember that was kind of the first time I sat back and thought, wow, pitcher has a stiff neck. That's going to be a problem coming back. And, the pitcher has to turn and look over the lead shoulder, especially from the stretch position to acquire the target, stay on the target. And so that's really kind of what started me thinking about this whole thing of neck mobility with athletes, and in particular overhead athletes. I'm an overhead athlete myself. I was a fast pitch softball pitcher, setter in volleyball. And then I started playing tennis in my 20s. And, intermittently, I had experienced a stiff neck, like we all do, the 3 to 5 day neck mobility deficits kind of thing. And I can tell you, it's hard to set a volleyball to somebody when you can't look up. It's hard to serve a tennis ball, right? And so that's what really started me thinking about the neck and putting some more focus on the neck. During that time, I was also going through manual therapy training. And Stanley Paris, of course, is one of my mentors. And, one of his big focuses is the neck. And so it was just kind of a nice pairing to start to drive my interest in the neck. And then in 2012, Pete Blandpede, called and asked if, I would be the clinician on the neck pain guidelines work group for the academy. And so that's how I was involved in that group. And that was such a huge eye opener from a research standpoint. Obviously there were some fantastic expert clinician researchers on that team. And I got to realize the knowledge base that's out there, but also the gaps in the knowledge around the neck. And there's obviously with that a big focus on folks with neck pain. But what I'm really interested in at this point is neck function and neck dysfunction in people who actually have other conditions and other problems, and from the standpoint of sport performance, as well as just how we navigate our environment in general, and really how integral the neck is. Even as you and I are sitting here talking, we're moving our head and neck constantly as we gesture. So think about older populations with neck stiffness, trying to accommodate different things in the environment. So all those things that started to coalesce in the 90s, and then through what I've been doing have just, taken me down this rabbit hole of fascination with neck function and how it's so integral to how we survive in our environment and how we perform different tasks.
So what did you do specifically for the CPG? You said you were the lead clinician. Like, what did that look like?
No, I don't mean lead clinician, but I was, when you put those teams together, you're bringing people who have different skill sets and different backgrounds. So you have people who are real research focused, and then you have people who are clinicians, because you're looking for different kinds of stakeholders within that group. And so I was really brought in for my clinical expertise as an orthopedic manual physical therapist at that point, not because of any kind of research expertise I had. We had people like Anita Gross, Jim Elliott, Dave Walton, who really had the research expertise around that. And then some of us were brought on really from the clinician perspective, because we needed to develop something that was a framework that was user friendly for the clinician, as well as for educators. I was teaching at the time too. And so I was looking at this whole process from the lens of, is this something that's going to be useful to drive clinical practice for me as a clinician? And is it something that I can use as a framework for students as they become novice clinicians?
Okay. And then in your time at UConn, have you spent some time lecturing or labs related to the cervical spine, and how has that gone?
Yeah, so at UConn right now, we have a musculoskeletal team. There are four of us. Three of us are AOMPT fellows. We're all board certified in orthopedics. So we've got a good team teaching the musculoskeletal curriculum. And I teach primarily the spine content. And I also teach a manual therapy elective on top of that. So I get a chance to really, stand on my soapbox and preach the neck to our students here at UConn.
It's very cool, and it was kind of almost embarrassing when you said, we use so much of the neck to gesture and nod and move our head around during conversation, and to agree with you, I nodded my head. I was like, oh man, this is getting meta. So you talked about Pedro Martinez and neck mobility deficits in pitchers, and then you went on to publish a study on this. So do you mind explaining to the listeners what the findings of that study was? I believe it was published in 2020.
Yeah, sure. So that was my doctoral dissertation. I came to the research world late in my career. I've been practicing since 1989, and I came to the research world later on. I took some different paths along the way, but that was my doctoral dissertation, and so we had already done some pilot work on that back in as early as 2016. We'd done a small study with one team, trying to get a sense of whether neck mobility might be important both for hitters and pitchers. And what really came out was that the cervical flexion rotation test, so upper cervical rotation was important, and neck flexion might be important. So we started taking a look at that. I backed up a little bit because I also wanted to get a sense of what does typical neck mobility look like in pitchers, in healthy pitchers, because just like with the shoulder, you have to think in a unilateral type of sport, there are going to be some kinds of adaptations that occur with doing something from the time you're 8 years old. So again, we've done some small preliminary studies, and we did find that looking at baseball pitchers compared to position players and compared to non-overhead athletes, the pitchers seem to have more neck extension, about 14 degrees more neck extension than position players, and versus non-throwers as well. So the position players looked, fairly similar to our non-overhead athletes. And initially that surprised me, but when you think about the follow through, you can think about some of the adaptive changes that might take place. You've got a head that's actually staying fixed in space as the body rotates and flexes around it during the follow through, and so we think that probably accounts for that. And so, we looked at this idea of typical neck mobility, and then trying to follow up on our initial results in the preliminary study on whether neck mobility was related to both time loss injury. So did a pitcher miss more than a week from the college season? And then also pain and disability, because we know from some of Zach Kerr's work that college baseball players have some of the highest non-time loss injury. And so what we're talking about there is complaints of pain and disability, contact with their healthcare provider that doesn't necessarily have them missing time, but they're probably not performing well, and they may not be feeling particularly healthy. So we looked at both time loss injury as well as pain and disability. And we used the functional arm scale for throwers to do that. And if you're not familiar with that, that is a questionnaire that covers a number of different domains, but as part of it, it has a pitcher specific module. And it really, I think, does a good job capturing how pitchers are functioning during the day. So, there are a number of region specific and even baseball and sports specific types of PROs that we can use. But I like the FAST. I feel like it really captures what pitchers care about and how they might be impacted on a day-to-day basis. So we utilize that as our patient reported outcome. So what we did is during the preseason, we had 3 college baseball teams. We recruited pitchers from those teams. And during the preseason, we measured the baseline PROs as well as neck mobility. And we also looked at glenohumeral mobility as well, passive glenohumeral mobility, because we wanted to just kind of have that in context because of some of the work that's been done around range of motion deficits at the shoulder and how that might influence risk. Sure. So we measured everybody preseason. And then during the season, the athletic training staff and or the pitching coaches on those teams tracked pitch counts for us, although we ended up having some issues with how we tracked pitch counts. And so we weren't able to really filter that into our regression model. But they tracked injury for us as well. So athlete exposures, days lost to shoulder or elbow injury. And then during that time, every week, the players completed, just took that quick 9-question module from the FAST about how they were functioning as a pitcher that week. And so we did that throughout the season. Come the end of the season, what we found is that 10 pitchers out of the 49 pitchers sustained a time loss injury, shoulder or elbow injury related to pitching. And when we looked at the clinical utility of our preseason measures in the neck, what we found was that the cervical flexion rotation test identified increased risk. So players who had less than 39 degrees on the cervical flexion rotation test to their dominant side. So if you're a right-handed pitcher, it was the right-sided cervical flexion rotation test under 39 degrees, they had over 9 times the risk of suffering a time loss injury during the season. When we looked at pain and disability, we found that neck flexion was also important. So those players who scored above a 10 overall on the FAST for the season, which is kind of a cutoff point for pain and disability on that particular score, we found that if they had less than 64 degrees of neck flexion, they were over 10 times more likely to report pain and disability consistently across the season. So that was interesting to see for a couple of reasons. Number one, the flexion rotation test was important in our preliminary study, and that seems to follow through in that narrow kind of validation study we did with the 3 teams. A couple of things to consider: that when you look at things like confidence intervals, the confidence intervals are narrowing as we're doing the repeated studies, but the confidence intervals are still pretty wide. And so that's something that we really need to address, that we are addressing in this next study. We have an NATA Research Foundation grant that we're looking to expand and validate that. In the 2023 season, we've got 8 teams that will be following. Same kind of model. We've honed it a bit, so I think it's going to be a little bit, as far as methodology goes, even more sound. And we'll be looking to replicate those results, specifically looking at the cervical flexion rotation test and neck flexion.
The cervical flexion rotation test versus regular neck rotation, the fact that you found significant or interesting results with one but not the other was surprising to me. Do you have any thoughts on that?
Yeah, me too. Actually, the whole thing was surprising to me even when we did our preliminary study, because my initial thought going in was that non-dominant rotation would be something that drove this, right? You don't have enough, if you're a right-handed pitcher, you don't have enough rotation to maintain your head toward the plate. You would imagine there might be things like early trunk rotation that happen in the pitching motion. So that's really where my head was when we started. And what we found kind of flipped that a bit in realizing that it might be later on in the pitching motion that really kind of affects some of these changes. So the ability I've kind of changed my perspective on this to that ability to maintain head stability. And that's one of the reasons I think the dominant cervical flexion rotation test comes into play, because I do think that it's a component of being able to maintain your head, in space while your body's rotating around it.
Mm.
Does that make some sense?
It makes some sense, and
Yeah.
it's tough, and that's the nature of our profession. Is it's a lot of speculation, and it's often difficult to put our thumb on any one thing.
Mhm.
You had speculated in the discussion from this study that perhaps compression of the nerve roots as they exit the cervical spine on the dominant or the throwing shoulder, perhaps that had some muscle function changes, and then that could make sense as you're thinking about deceleration of the arm, because that's probably, if not the most important period of the shoulder's health during the pitching throw. And so I thought about that, and my eyes got open to that as being a possibility after experimenting and having a professor experiment around with thoracic manipulations and then retest of rotator cuff strength. And I was like, my mind was blown. Like, for example, someone wouldn't be able to hold their arm up in ER 90-90 and then have someone push and test the external rotators, give them a quick thoracic manip, and then they can hold the position. And so ever since then, I'm like, okay, maybe this voodoo stuff is more possible. Maybe positions of the head will affect the function of the nerve and the neuromuscular system. Does that all make sense to you? Like, is that kind of where you guys are coming from?
Yeah, I think there's so much room to explore here. And the interesting thing is that it's not new necessarily. Like this notion isn't new. You can go back to the late 80s, 1986, an article by Young, another one by Lee, looking at overhead athletes and, positing this very thing that there may be some, intermittent compression of the nerve roots, in the neck. And when you think about both the tennis serve and as well as the pitching motion, there's a lateral trunk tilt. And so with a lateral trunk tilt, again, in order to keep your head oriented in space, you'd have to accommodate some more side bending. So now you've got side bending, now you've got extension in the follow through, all those things, are we seeing, some kind of subtle, neurological changes that really influence not only the rotator cuff, but even further down the arm as well. And I think that we can probably look, most of us who work with patients with neck and shoulder pain can go back to clinical practice to those folks who have been referred with a rotator cuff tear because they are presenting with rotator cuff weakness. As we assess them, gosh, this just doesn't seem like a true rotator cuff problem from the standpoint of a tissue pathology. Go in and do a little bit of experimenting with some symptom modification, traction, distraction types of things. Suddenly their strength's 5 out of 5. Whoa, what just happened? I have the luxury of having twin nephews who are competitive baseball pitchers, and so I get to experiment on them all the time. And they're willing participants. And I evaluated one of them this spring who was having some shoulder discomfort. And when we evaluated him, we found that he actually had some changes in the neck that we felt were related to that. He came in with shoulder external rotator weakness on his dominant arm, did some distraction with him. And all of a sudden now he's got, 5 over 5. So, that's obviously those aren't morphological changes happening within the rotator cuff musculotendinous unit. There's a neurophysiological component to that. And so the thing I'm really excited about with this line of research is, it feeds my passion into the whole notion of baseball and overhead athletes and how neck function relates to both performance as well as injury. But I think that there are greater implications for general populations who have shoulder pain in particular, when we start to really consider the role the neck plays in the etiology of some of those, even almost from a subclinical standpoint in the neck. A lot of those people aren't complaining of neck pain, but they may have some neck dysfunction that's really contributing, if not a primary driver, at least, something that we need to consider from that standpoint.
And I've been hearing mumblings from clinicians around throughout this process for me with NecksLevel, where I'm focusing on the neck with this product, and then I have clinicians telling me, like recently I started just focusing on the neck for my shoulder pain patients, and it's been a big improvement. We'll just focus on stability of the neck and strengthening the deep neck flexors and that type of thing, and then their shoulder pain goes away. And so all this stuff, it feels like voodoo, but it's the constant concept of regional interdependence and all that good stuff. So it is very interesting. And what you just made me think is maybe all of our professional pitchers should be doing traction right before they go out onto the field. Things like this, like super easy to implement options to whatever, make the nerve roots more happy. However, we're doing that.
Yeah, that would be a fascinating study, wouldn't it? Right, the test retest on things not only like the muscle function, but then looking at things like pitch velocity, and are there any implications for that as well? Yeah. Well, that's why I get super excited talking about this, because I think there's so much room for exploration in all of this. And I don't think it's voodoo either. I understand why you might say that, but there are anatomic relationships, but from a muscular standpoint, neural as well. There are biomechanical relationships. I mean, I think we all accept this notion of like from the bottom up affecting the kinetic chain. But this is where we've kind of looked at it and said, wow, we're looking at the head and neck as a top down driver of mechanics for people as well.
When I say voodoo, I don't actually mean it. I just think that
I know,
some of
no,
the
I know
stuff
what you.
we do
Yeah,
is
yeah.
is magical. Like I hold manipulations in the magical realm. Like it doesn't make sense to me how much of an impact it can have, such a quick treatment. The transient effects of what we can do are very interesting. I think that's something I would love to research is, what kind of changes do you see for shoulder function when we work on the neck, but then for how long? Is it 10 minutes? Is it 3 minutes? Is it an hour, and then get through their first couple innings of pitching? It's all very interesting. Where do you see this kind of playing out for the general population? Do you feel like that could be integrated into regular outpatient orthopedics, or do you see other strategies that we could explore for shoulder pain, neck treatment, these kind of things for the general pop?
Yeah, I mean, I already integrate it, and that's kind of some of my training. Really did look at the first thing you do in a patient coming in with non-traumatic shoulder or elbow pain. The first thing you do is assess the neck, and so that's certainly what we teach here at UConn as well. And that's kind of been my treatment approach. Is we start out looking at the neck and saying what's the just a simple screen, looking at any kind of pain reproduction, et cetera. But then as we move through the physical exam, we're considering things like neck mobility and how that might affect how somebody even reaches or does that type of thing. I consider whether people are left or right-handed. Some of our research with the pitchers has suggested that neck mobility is actually different whether you're a right-handed or left-handed person. We certainly know that shoulder mobility is different because lefties live in a right-handed world. So right-handed people in general tend to be a little bit less symmetrical than the left-handed folks. So there are those things to consider. And we look at impairments at the neck and how those might influence how people move at the shoulder. And even further down with that, and looking at whether someone with carpal tunnel syndrome actually has some component of cervical involvement that's contributing to that to that kind of persistent pain that people might be finding.
Okay.
Yeah,
Interesting.
so I think it already has applications to the general population, and I do hope that clinicians are out there considering the neck and people who have any kind of upper quarter pain complaints, but I think more specifically, it has some real implications for folks with rotator cuff problems, and that's in baseball specifically, looking at the kind of heightened interest in things like thoracic outlet syndrome. So I think that those are probably the big places for room for improvement and real impact.
Selfishly, I always project my own story into this. I had a small whiplash injury when I was young, like in high school. And then ever since then, I've had chronic neck pain that comes and goes. Several years after that, I had bilateral shoulder pain onset as a result of volleyball. Like you, I'm doing a lot of overhead activities. And then I find out through PT school, I have positive sulcus signs on both sides, which, perhaps I have some inherent instability in my shoulders. But, all the while I'm still dealing with chronic neck pain and it coming and going, and acute flare-ups of a facet or whatever, difficulty turning my head while I'm driving. So all these things are like my wheels are spinning, and it feels like that could be quite the possibility that this is all stemming from my neck.
Mm-hmm. Yeah, when you can't turn your head or look up, it changes the way you move. It really changes the way you move. Yeah.
Yeah. Now, can we talk a little bit about the CPG and then how you guys have brought that into UConn? and your DPT curriculum. I'm interested specifically in what tests you guys are giving to your students, like what tests that you want them to look at for the neck, even if it is rotator cuff involvement. What are the tests that you guys are prescribing?
Yeah. So, you know what, one of the things that we really do emphasize with the CPGs, and one of the things I liked about it was taking you through the different levels of the examination. So, starting out, first of all, thinking about the history and what's really important. Is this traumatic pain or is this atraumatic pain, et cetera? And then going through the medical screening process. And so, that's one of the things that I think is the thing I like, is that initial step of really getting that overall picture to start with of what we're dealing with. And then moving into the physical examination itself, looking at movement. So from the standpoint of, quality of motion, quantity of motion, reproduction of symptoms, that's the first thing we go into, is your typical kind of active and passive range of motion overall impression screen. We don't put a lot of emphasis on numbers initially. In particular, we're trying to get a sense of how people are moving. And then some of the important region-specific tests, that we've identified. Certainly the cervical flexion rotation test, obviously, right? So that one's near and dear to my heart. It is reliable. It's useful in looking at folks who have neck pain with mobility deficits, as well as neck pain with headache. And then, of course, we're finding it to be useful in other areas as well. But from the standpoint of the CPGs, that's where you really find some good utility for that test. The neck flexor endurance test, that's another one, especially in our patients who are complaining of traumatic pain. The movement coordination impairments group, which is heavily focused on folks with a whiplash associated disorder. That's certainly gotten a lot of attention, and I think that's one that surprises a lot of patients in the lack of endurance that they might have there. The craniocervical flexion test is another motor performance test that I think is important for folks who have the movement coordination impairments as well as neck pain with headache. So those are tests that fall into those categories. Mm-hmm. And then, of course, when we get to neck pain with radiating pain, we're looking at trying to utilize the cluster to help our decision making. And so that's Sperling's test, looking for reproduction of symptoms. That's looking at a distraction test to see what we get from, and it's the distraction test obviously is more about symptom provocation, or alleviation, but we also look at some other more objective things like the motor performance in the upper extremity when we're looking at the distraction test as well. And then the neurodynamic mobility assessments.
Could I pause you on the distraction test and what you're doing with the upper extremity? What do you mean by that?
So it's kind of what you talked about before with that thoracic manipulation. And, if we've identified during that initial examination, because we use the cluster kind of high up in the exam to try to identify what direction we should go down that decision tree. But if we've identified that, during our neuroscreen, that's another, kind of the nuts and bolts of the exam, during our neuroscreen, that there's any kind of motor weakness, then we're going to go back and we're going to do a distraction test and do a pre and post on the motor weakness to see if there's any change. And I think that's going to inform us as well.
That's a nice thing to integrate. I haven't heard that before. I like that.
Yep. And then from a test and measure standpoint, one of the other things is using the algometry for pain pressure threshold. And that's something that, there was still emerging evidence at the time that we were doing the evidence review. This was published, the neck pain guideline revision was published in 2017, but keep in mind that we started it back in 2012. And so, really there's that lag time, right? But by the time you publish, there's already new information coming out, but algometry did make it in there as kind of an emerging evidence. And that is a component of what we use, because we teach guideline-based assessment and intervention, but we also try to layer in a mechanism-based approach to patients who have pain, whether it's some kind of acute or tissue-based pain or persistent pain. So taking in more of a mechanism-based approach, looking at whether it's nociceptive, nociplastic, neuropathic, et cetera. And so we layer that in, and I think that's where one of the places that the algometry can be helpful.
Interesting. Okay. Yeah. I would love to end up talking to some of your students or new grads and see how they are able to integrate this into their early practice. I think some of the programs I've been exposed to can do a really good job of teaching students the framework, and then they have something really concrete to hold on to right when they go to the clinic. Some programs might be like, here's a bunch of things that you can do, and then other clinics, like you said, or other universities, like you said, might have more of a flow for students. So I think the differences there are really interesting, and I would love to see how that ends up presenting itself for your UConn students. Uh, One thing I was really excited to talk to you about is what feels like the boogeyman, which is neck strengthening for patients with neck pain. And perhaps this is no longer the case where people are worried about strengthening the neck as it relates to people with neck pain and damaging the cervical spine. So, it feels like, and I'm new to the field, but it feels like if a couple of decades ago, neck strengthening was the boogeyman. It was something that was avoided. They thought you would do harm to the neck by treating in this way. Do you remember this? Can you speak about this period at all?
Yeah, I've been around long enough, definitely to remember that we were doing kind of multi-angle isometrics with two fingers kind of thing for our patients when it came to strength at that point. I never quite understood, why the neck was so special and why we had to protect it from that in that manner. And so it's interesting because then you had the evidence coming out of some of the group over in Scandinavia with Milanen and so forth, finding that actually a higher load, you've got office workers with persistent neck pain, higher load, higher intensity kinds of exercise was actually superior to what people were doing with endurance and stretching. That was probably the first time the light bulb went off for me, was reading some of that research. And I know, in that research, they were finding that while, people improved in strength and improved in range of motion with different modalities of exercise, that the higher load types of things resulted in both increases in strength as well as range of motion, and reductions in pain and disability. So that was really the first thing that started me thinking, what, we need to challenge our patients more, when they have neck pain, when it comes to the neck. Interestingly, we did, in our preliminary work, we did look at neck strength with the baseball players too, to see if that was associated with risk. But what we found, as you'll appreciate, is that assessing neck strength is really difficult. And that might also be one of the reasons that, that it didn't develop, and that, 20, 30 years ago, we weren't doing much with exercise prescription at the neck, is because, we didn't have a good way to assess it as well.
Right. Now, when you say didn't have a good way to assess it, are you talking about because MMTs weren't reliable, or because handheld dynamometry wasn't where it is today, or that wasn't reliable? What do you mean?
Yeah, even handheld. Excuse me if I keep waving my hand. Our offices are down by the horse barns, and so we tend to have flies in the building, and I have one joining me today. So if you see me batting something away, that's what we're doing. That's what I'm doing here. Even handheld dynamometry, it's really difficult, especially if you're doing any kind of team-based screening with multiple people coming through. In the clinic, it's probably a little bit easier. But I know myself, I'm on the smaller side physically. And so if I'm working with a population of athletes, football teams, wrestlers, baseball pitchers, it's actually pretty hard for me to maintain any kind of stability against them. So now you think about, you're doing 6 different directions, you're doing 3 trials per direction. And now if you're doing multiple people, we found that the reliability definitely tanks as you continue doing multiple people. We would select the strongest person in our group to try to do it. But it was a real challenge. And so we didn't find any kind of relationship, but we also actually didn't have any confidence in our results there, in our measures. And so that's been something that I've been looking to determine over the years, trying to find different tools and ways to assess neck strength. And I think a tension meter might be one of the best ways to do it, because then you can use some kind of a strap or belt type of apparatus, and have people pulling and pushing, and you can get that isometric strength. You can get time to peak torque and those types of things. But I honestly don't think we have a really good way to measure that incorporates movement. We still only have measures that, to my knowledge, we still only have measures that really look at isometric, force measurement, as opposed to really being able to measure with any kind of movement capability like we have in other areas.
Yes.
We don't have Biodex attachments for the neck, to be able to look, to look at things like working range or anything like that.
Are you familiar with Formula One racing?
I'm not very familiar with it, but I know what you're talking about. Yes.
Yeah, so Red Bull is one of the top teams with that in that field, and they have this, I believe, an isokinetic dynamometer for the neck, and so they have their racers, grunting and grinning and then pushing through a range of motion against this big machine, and so it might be out there, but it likely costs $10 million, and it's.
So I'm really excited to hear it's out there, but you're right. When it comes to like clinical assessment or being able to take it out into field-based types of research or programming, I think we're still lacking. But I'm excited to hear that. I'm going to have to check that out.
I'll send you the video of it. Yeah, it's their facility over in I believe in Austria that has it, so you can take a trip out there. So we have MMTs, we have dynamometers of sorts to measure neck strength. What do you think about tools for strengthening as a way of measuring neck strength? So for you, we have the NecksLevel, we have the Iron Neck. Do you use or think about using those tools as a way of measuring neck strength or endurance or things like that?
Yeah, I'm glad you asked that question, because yes, and for two reasons. One is it's clinically applicable. So anytime you have a measurement tool, it's got to be something that clinicians are going to use if it's going to have, you're going to have any impact on practice. And so that's one of the reasons in things like the athletic setting, we actually looked at the Iron Neck. And so we looked primarily at adapting it to be able to measure mobility as well. So the folks at Iron Neck were kind enough to mock up a prototype for us that allows us to measure things like rotation. And we have an inclinometer that we attach to it to measure flexion extension. And, there's some benefits. We actually have an article that'll be coming out looking at the CROM, of course, for mobility, the easy angle, as well as the Iron Neck, and just not to look at any one, being the one that you can choose, but looking at when they seem to be most appropriate, when they're applicable, and just understanding the limitations in measurements. And I think it's the same thing. We look at neck strength. I think that there are tools that we have that we use for training, that we can use for measurement as well. Whether it's looking at how many repetitions someone can do at a certain tension level, those types of things, or adding on some kind of, sensor apparatus, force sensors, et cetera, that actually give you some other types of objective data too. And when you're talking about the clinical sense of things, I don't think you necessarily need, the fancy sensors, et cetera, to get some of the information you need. When you're talking about research, screening, and making those kinds of clinical decisions, that's where I think some of the more objective measures can help. If you do have things like cutoff scores available from the research that might help you stratify different people.
Interesting. Okay. And then one thing I'm very interested in and perhaps happy about with the NecksLevel is that it offers a way to get after neck rotation strength. What roles do you think rotation strength has, if distinct from the other motions or muscles of the neck? Do you feel like there's any interest there versus isometric strength or the straight plane strength?
Yeah, I think there should be. If there's not, there should be huge interest in that. And I think it's like a lot of things we do. A lot of the things we do are sagittally oriented, and we don't see enough moving into the other planes. As you like to bring in you said your personal stories, and myself, I'll tell you that I'm someone who has suffered from persistent neck pain at different times. I don't think there's anything horribly wrong with me necessarily, right? But depending on my physical activity at the time, stress levels, sleep, whatnot. And the thing that's given me relief is resisted neck rotation. So my go-to when I've been sitting at my computer for hours at a time is actually a resisted neck rotation. And that seems to alleviate things for me more so than any other direction. But you and I talked a little bit too about this notion of eccentrics, right? Eccentrics have been explored in obviously managing patients with tendinopathies, and things like reducing recurrence and or hopefully occurrence of hamstring strain, and how, we can build length with strength. Right now, Mary Claire Capetta, who's one of my colleagues here at UConn, she and I are looking at utilizing eccentric exercises to improve shoulder mobility, as without losing that strength component in that kind of transition. And I think that's another place that we could look at implementing eccentrics in patients with neck pain and or limited mobility, because you gain both strength and length. And that's one of the things I think you and I talked about with the NecksLevel is it's actually easy to implement eccentrics in multiple directions with the NecksLevel. And that's something that can be difficult to implement. And if you make it simple, then patients, athletes, et cetera, are able to follow through with it.
One of my strong biases now is that perhaps someone with neck mobility, maybe we'll leave osteoarthritis of the neck aside for a second. Someone like my age or your age, if they have neck stiffness, one of my biases is that I don't know that stretching is the best way to go after this stiffness. And I would argue that some muscle training, perhaps eccentrics, like you said, would perhaps be a better way to go after it. I've even seen benefits from just doing isometric holds for different exercises on the NecksLevel, and improvements in range of motion after. So is my bias unfounded? Do you feel like there's something there that perhaps cranking on the neck in one direction or the other is not the best way to go after a range of motion deficit?
Yeah, I share your bias, definitely. And, if you think of, foundationally as a manual therapist, if I'm looking at movement restrictions, I'm trying to get a sense of, is there an arthrokinematic component that I need to address first, right? And then if once that arthrokinematic component's been addressed, then I'm moving on to things like muscle length, and then utilizing utilizing it with good movement control throughout a range of motion. And I would say that my younger self had a real bias toward things like facet mobilization and improving arthrokinematics. I still think that's part of the framework of the assessment piece of it. But I agree. Actually, at my age, I may actually have some osteoarthritis. Right?
Well, you're 35 though. I didn't know.
Yeah, no, I hit a milestone birthday last week. So, but definitely less so than I thought, in the past. And I think a lot of what we see, from the stiffness sense. Well, if you truly have changes at the joint level that are limiting your motion, they should be fairly consistent. They shouldn't change from day to day and week to week, et cetera.
Right.
And I know that's what I find in myself. It's what I find with many patients is, one day they come in and they can't turn their head, and without any interventions, you might see that, they're 7 days later, they're actually able to move in a different way again. And I do think that goes to things like neurophysiological components of perceived stiffness, as well as the fact that, if you have sedentary behaviors, and so that distinction between like lack of physical activity, but sedentary behavior. So I went out and I ran 2.5 miles this morning, but if I sit for 8 hours at my computer today, I will know it in my neck in the sense of stiffness, not because there's anything wrong with me, but there's a level of stiffness that develops. And so I do think that it's things like physical training, behavioral modification, in addition to the joint mobilizations, manipulations when they're indicated, interventions to target muscle length if there's a true muscle length deficit. And so that's where I think pairing, our interventions with our assessments, really what we're finding from our assessment is important, because you might have someone who has a muscle length deficit. They may benefit from stretching, although I have definitely moved more toward using eccentric exercise to drive changes, like long-term changes in length, as opposed to stretching.
Yes, I see. Now you brought up you sitting at a desk for 8 hours today, and how your neck will feel that and will tell you about it. As a clinician, it's always interesting for me to think about what I ask of my patients, and sitting with good posture, perhaps if they have neck pain and they have a desk job. Where do you feel like posture comes into all this? And do you feel like it's realistic, knowing the human body, for us to be sitting with good posture for 8 hours a day? What kind of recommendations do you have as it relates to posture, endurance of the postural muscles, and managing neck pain at the desk?
There's a lot to unpack there.
Yeah, sorry, that was a
Yeah,
broad
no, no,
question.
no, that's okay. It's a great question, right? Because I think that we are drilled as students and young clinicians to think that, posture, 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 right? So I think the short answer to when is posture important, or the easier answer is when it changes a patient's symptoms. And so, if you have someone who's sitting in a what we would consider a poor posture, right? Kyphotic posture, posterior, tilted, forward head, extended posture, and they're having pain, and you make a change and they say, oh, you know what? Actually, that doesn't hurt anymore. Or, I feel better when I'm in that position. So, that's one component, I think, is when changing the posture modifies the symptoms. I think it's important for that individual patient, right? That said, if you think about things like an 80-20 rule and moderation and those types of things, I do think that there are static postures. And I'm not sure whether it's the posture itself or the fact that people are static. That's the real problem, right? The research has been a little bit equivocal as to whether posture plays a role in neck pain. And I think it also evolves with with evolving generations. There's some recent research suggesting that adolescence, the forward head posture might actually be associated with neck pain, and that might be associated with newer technologies and phone use and things like that. So I think that's a question that I don't think we have a great answer to. And so I think the best answer is it makes sense for people to have good setups and support and so forth. It makes good sense for people to have the postural components from a muscle performance standpoint. I think that's probably the place that we have the most work to do, as opposed to telling people you got to sit up straight, use this chair, et cetera. If they're more active, if they have better control with the postural muscles, they're probably likely to adopt some of those, better postures organically anyway. And that's where, one thing I was hoping to actually be able to mention today was there's a lot of attention paid to the neck flexors, right? And I think there's not enough love for the neck extensors. And if you look at the research into whiplash associated disorder and exercise prescription, there's a nod to the neck extensors, starting off with some isometrics, but then moving into the pillar kinds of motions. And one group that probably has done the best job in sports when it comes to the neck is wrestlers. They actually use their head and neck, right, sometimes to actually propel themselves and support themselves and prevent whatever. And so that's probably one of the sports that I've seen the most attention to actual neck strength, and in particular with the extensors. But I think we could probably take a lesson from them when it comes to both preventing concussion from the standpoint of being able to absorb, deflect, et cetera. But then also people recovering from concussion injuries that, of course, have concomitant whiplash effects that go along with it. People who have had a whiplash associated injury, as well as people who might need that endurance for different types of prolonged activities.
So what strengthening exercises for the neck extensors or for the neck in general are you preaching these days? Do you like resistance against gravity? Do you like the cable column with something tied around their head? Like what do you think is a good way, understanding the technology limitations and clinical budget challenges? What do you think are good ways to strengthen the neck?
Yeah. I'm not sure there's any best way. And that's one of the things I hope people appreciate, is that when we're always looking as clinicians and researchers, we're always looking for the best thing, right? The best exercise for this. And, the best exercise is the one that's going to accomplish your goal within the framework of that patient and that patient's, kind of belief system and ability to adhere to what we're trying to get them to do. And so I have a variety of things. And my favorite two words my students know are "it depends." Yes. In many patients, it's simply doing things like, prone with an initial, retraction, gradually working that into whole body movements, sustained holds, that type of thing. But then for others, depending on what they're doing, I might have them supine in something like a red cord, where we're actually having them ultimately try to elevate their body using the neck extensors. I like some of the upright things. We had a goalkeeper treated for prolonged recovery recovery concussion a couple of years ago. And this particular goalkeeper got, fantastic care from the sports medicine team. But the one element that was missing was addressing the neck. So this had been a 5-month, time point by the time this person came to me, with persistent pain, deficits in vision, dizziness, nausea, the whole thing. And it was really the neck that was the missing piece of it. And so trying to integrate those different systems, as well as then increase the strength and the kind of capacity, the work capacity of the neck. That was the thing that really seemed to bring her those final steps. But what we did, we had her on the cable with that. And so we had her doing things where she was doing walkaways, initially against, once we got her to the level where we could work her upright, doing walkaways with the cables, and then ultimately having some kind of tension on the neck extensors and the neck flexors. We varied it up as she was doing different functional tasks. So we had her on the Lozier speed pulley with the cables around her head, resistance, some kind of resistance, and then I would be feeding balls at her in different directions that she had to reach for. And I obviously didn't have her diving with the cables on, but things that were functional to her, having to react, respond, move and maintain while keeping some kind of stability to the neck as well. And so we incorporated those types of things to try to kind of within a functional activity increase endurance as well.
Sure.
So I guess the short answer to your question is, I think there are a lot of good ways to incorporate neck extensor strengthening, or just neck strengthening in general. We've got some great clinical tools, that have come out, including the NecksLevel. You and I talked, and I liked that for a number of reasons because of the ease in rotation. Up until then, my go-to exercises for resisted rotation were with the iron neck, but you have to have the equipment to do that. It's not something that multitudes of patients can do at home. We use it in the athletic training room here with the sport performance program. And so it's a great tool, but it's not for everybody. One of the other things I used, I think I told you, it comes out of the whiplash research, is the TheraBand in the mouth, tying a knot in the middle of the TheraBand. We wrap a gauze around it, putting it behind the teeth, arms up on the wall, and then doing rotation, which gives you a great line of force. But a lot of people really balk at the idea of putting, a TheraBand.
Really?
Yeah, surprisingly, right? So having simple tools that can work on both frontal plane and the transverse plane resistance, I think is really important to us in neck rehab.
Full discretion, I'm currently pitching to investors to invest in NecksLevel and in the future consumer model. And one of the reasons that I suggest that NecksLevel is so important to develop and get out there is that we lack the proper or appropriate exercises for patients. And I do reference the band in mouth rotations and the taste of gauze or latex or whatever they're feeling in there. And so if that ever comes out, just so you know, I have poo-pooed that. Yep.
It's a great exercise. It has some limitations, right?
Yeah, of course. Everything does.
Yeah. Well, how many years did we teach people to, cross the TheraBand over and do those exercises, which, again, I think has some value. The problem with that one is I find that when people don't like to do it for some reason, they're just not going to do it. And, right. It's cutting into my eye, or I can't hold my arm up there for long enough, or whatnot. That's when people start, failing from the standpoint of adherence. And so anything we can do to make these exercises simple and easy for people to follow through on, I think that's a benefit.
Of course. Well, thank you so much for your time today. I know you're very busy, and I really appreciate the opportunity. I think that was very interesting. We'll see what everyone else has to say. So thank you again for your time. Are you active on social media? Is it something that people could see you and check you out on, or not so much?
Well, I'm not terribly active. I'm probably more of a consumer on social media, looking at what other folks are doing. It's probably something I should improve upon. But they can check me out. I'm on Twitter at LLDevoPT. That's my Twitter handle. So you might find a little bit there, or the UConn Institute for Sports Medicine.
Very good. Well, thank you again for your time. It was a pleasure.
Yeah, thanks so much for having me. This was fun, and I can't wait to check out the Formula One tool that you talked about.
Yes, I will send it to you. Okay.
Thanks, Scott.